Hello, dear students. Today we have the third lecture in the course of Traumatology, Orthopedics. The lecture is devoted to open fractures and purulent inflammatory complications of open fractures, just such a formidable blessing as traumatic osteomyelitis. In this lecture, we will look at metadiagnostics, methods of treatment of open fractures and traumatic osteomyelitis. So, what is the concept of an open fracture? Open fractures are fractures in which there is a wound in the fracture zone and the area of the fracture itself directly communicates with the external environment. Here you need to approach it carefully enough, because not always the presence of a wound on the surface of the skin can indicate that we have an open fracture. A lot of doctors in terms of overdiagnosis often interpret open lanes in this way. That is, even the presence of an abrasion directly above the fracture zone can be counted by many as an open fracture. Of course, it is necessary to look deeply, both deep into the wound itself, and the essence of this concept. That is, it should be mentioned that there is such an important concept as a trauma zone. It outlines the true dimensions of the wound and, naturally, in contrast to the early skin. Skin wounds are just a window through which the true wound can be connected to the external environment. In many cases, the window may be small, while the main wound is quite extensive. And in this place there are wounds associated with damage to the rupture of muscle tissue, for example, with injuries to the thigh, lower leg, with damage to the tendon ligamentous apparatus. One of the most important points in assessing the difference between an open fracture and a closed fracture and the presence of a wound of the skin is damage to the fascial structures, which are strong enough, are a serious obstacle and, let's say, a border for the spread of that infection, which can get directly into the wound. And as a consequence of all this, damage to the ligamentous apparatus, not even ligamentous, but damage to the fascial apparatus, even if we do not observe bone elements directly in the wound, indirectly indicates that this is an open fracture. I hope you understand me in this case. Let's talk a little bit about epidemiology, that is, about those very statistical figures. Open fractures account for an average of about 3% of all limb fractures. This is usually the result of direct exposure to a large force and occurs most often with sufficiently high-energy injuries. Well, let's say that in road accidents, the percentage of open fractures is very high. When falling from a great height, open fractures are also often found. According to the localization of the injury, one of the most frequent localizations is our shin. 21% of all open fractures occur on the lower leg, and most often this is the same accident and fall from a height. A little less than 12% also accounts for formidable fractures, this is for fractures at the bit bar. 9% on the forearm, shoulder. Here you have noticed 51% is a different localization. And you will say here that, in fact, there are not so many segments of the finite left in our body with you. Yes, indeed, a very large percentage of open fractures account for our carpal apparatus. Well, people tend to stick their fingers where they shouldn't or where it's dangerous. Unfortunately, open fractures of fingers and hands are a scourge. The scourge in high-tech various devices. These are mechanisms, these are machine tools, and so on, and open fractures are very common here. In terms of the classification of fractures, let's try to touch such an interesting topic as the International Classification of the Association of Osteosynthesis in the context of this lecture with you. The classification was proposed by Muller in the 96th year. I won't say that I love the international classification very much. In our country, preference is still given to the classical classification, once described by Arkady Kaplan, which we have already met at the last lecture and definitely recall at every practical lesson in traumatology, but it is necessary to know that there is an international classification. It is in the context of the approach to open fractures that this classification is quite interesting. It suggests that we can standardize approaches, we can have some kind of algorithm of our actions depending on different types of open fractures. So, the description of skin damage rests with us in 5 different variations. Yes, the letters it is studied are called REOU and, accordingly, the 5 degrees of this REOU. The very moment of REOU comes from the English words intagment, that is, skin, and open, that is, open skin damage. So, REOL from the first degree is a minor skin tear. AOL of the second degree is a laceration of the skin less than 5 cm long, but with rasmogeny edges. Here are the first and second types. This, with all the desire, is not very bright, not very pronounced wounds. IOU3 is a skin injury already more than 5 cm long with more widespread reproduction, with non-viable edges, and it is quite possible, when we talk to you about the injury zone, there are also significantly serious soft tissue injuries in the depth of such a wound of the skin. We will talk about them in the following sections of this classification. ANOU4 is a significant multiplication of soft tissues for the entire thickness. This is precipitation, these are skin defects. And, accordingly, IOU5 is a separate path, it is a common skin detachment. The next section of the international classification is the description of muscle and tendon injuries in open alleys. So, muscles are a muscle, tendon is a tendon with you and me. Therefore MT1 is muscle damage in this case, there are no powerful injuries. That is, there is only damage to the skin. MT2. In this case, it is limited muscle damage. Only one muscle group was affected in the case of an open fracture. MT3 is a significant muscle injury when there are 2 damaged muscle groups. MT4 is a muscle defect, it is a tendon rupture, it is a common muscle injury that subsequently leads to necrosis of this muscle tissue. An MT5 is a compact syndrome. Crushing syndrome with a large area of damage to soft tissues, in particular muscles, and other soft tissues, such as tendon, ligamentous apparatus. The next section of the international classification is the classification of neurovascular injuries. NV1 is a situation where there is no neurovascular damage. NV2 is an isolated injury to one nerve. HB3 is a local damage to the vessel. NV4 is a common segmental vascular injury, in which the nutrition of a sufficiently large segment of our musculoskeletal system is disrupted. And HB5 is the most severe, it is a combined neurovascular injury, including subtotal or even total separation. In fact, its own international classification is not of course widely used in our country. Then we will analyze the moments of treatment of open fractures in one slide, and here we have the opportunity to use a number of such simple rather concise classification signs to standardize the approach to treatment.
What? What do you want there?
Well, let's talk about the diagnosis.
Drop the jokes. You don't have a closed one there. Open break.
Well, to the question of humor. I think in the past let's talk about the diagnosis of fractures. In principle, there is no serious major complexity or any differences in terms of diagnosing open fractures from trauma with closed injury of the musculoskeletal system. All the same moments, characteristic, both relative and absolute symptoms are applicable in this case. Once again, it should probably be recalled about the concept of a trauma zone and the communication of a bone injury zone with the external environment. That is, with damage to soft tissues, with the risk of, say, reports of injury to the bone apparatus with the external environment clearly indicate an open fracture. The diagnostic moments in the previous classification nuances were also clearly described. Yes, that is, they can be observed both directly during the examination of the patient and when performing that part of the primary surgical treatment which is called revision, that is, an assessment of the condition of the wound. Quite often, when diagnosing open fractures, doctors face the difficulty that an open injury of the musculoskeletal system itself implies a sufficiently powerful mechanical effect on a person. And very often open fractures are one of the components of severe combined or combined injuries. Often, the patient, getting into the hospital, in this case is in a state of shock, because the injury is very serious. And the full-fledged moment, that is, a thorough diagnosis, in some sense, is temporarily postponed until the time when we stabilize the situation with the patient. When the resuscitators finish their work to stabilize the situation. And then we will talk about using not only physical techniques, but also instrumental techniques and making a more accurate diagnosis. To the question of the modern concept of treatment. Here we have several points on the modern concept of treatment. Let's look at them in order. So, the first item in this table is infection prevention. By itself, an open wound is already a gateway for infection. I think it's already clear and understandable. That is, our integumentary tissues, performing a barrier function, provide us with restrictions from the aggressive external environment. Prevention of infection is one of the important points that speak about the success of the treatment of open fractures. In many ways, everything depends on the early healing of the wound, on the complete restoration of soft tissues. Infection is the single most likely factor that can have a detrimental effect on the final result. Therefore, the main attraction on the spot, that is, directly during the provision of pre-medical, first aid, that is, at the scene of the incident, that is, at the hospital stage, is the right approach to first aid. This is the closure of the wound with a sterile bandage. This should be remembered by all doctors and not only traumatologists, but also, in principle, with your, let's say, pedagogical activity, when teaching ordinary people, that is, not doctors, you need to tell the rest. In order to avoid infection of the wound, the bandage should not be changed during the initial examination in the emergency department. Yes, since opening the bandage, I do not argue, there is always a desire, let's say, already at the stage of almost in the corridor to realize and understand, say, the seriousness of the situation with this patient. It should be understood that in this case we increase the risk of contamination, that is, the risk of contamination of this wound. Even with an ordinary conversation, with an ordinary cough, the corridor conditions, with all the desire, can never be compared with the conditions of the dressing room and operating room. The hospital flora that got into this situation can still further aggravate the situation, because in most cases the hospital handicap is resistant to antibiotics. Therefore, when performing an audit at the FO stage, the surgeon must comply with all antiseptic measures. He must be properly dressed. Do not forget about this too. This is a cap, this is a mask, these are sterile gloves, that is, all the norms that apply to work in the operating room. The next rather important aspect in helping patients with open fractures is the time of the operation. Open fractures are best operated on as early as possible, in the first 6 to 8 hours after injury, until the wound, which is a wonderful nutrient medium, does not reproduce this very microflora that got there when the integumentary tissues were damaged. If the operation is not performed in the first 6 to 8 hours, then it is better to treat the fracture by external fixation methods, that is, we will talk about this further now, by a two-stage method in which hardware fixation is first performed by external fixation devices and then you and I can already recognize the operation itself, which is associated with immersion in the wound. That is, it is by intermedullarity of synthesis or by bone synthesis. Alternatively, skeletal traction can be attributed to the options of external fixation, which is also widely used when working with open fractures. The next aspect of the treatment of open fractures is radical surgical treatment. That is, surgical treatment. Primary surgical treatment is a full-fledged operation. Therefore, all open fractures are fractures that will be treated surgically. That is, at least the FO of this patient will be performed. Therefore, an open fracture is an absolute indication for surgical treatment. Surgical treatment of a contaminated wound should be urgent, that is, it is not advisable to postpone it. That is, it should be carried out in the first 6 hours after the injury, after the patient's admission. With late surgical treatment, the risk of bacterial contamination increases and the development of infection becomes more likely. Surgical treatment of the wound requires the pedantic removal of all dead, non-blood supplied, non-viable tissues. We will talk in more detail about this stage when we consider the next semester of the firearms RODA. But already here and now it needs to be clearly defined that performing a thorough revision with an assessment of the viability of the tissue is a critically important part of the implementation of the FO. The remaining portion of the inferior tissue in the early period is a direct road to inflammation, to suppuration, and to the most serious consequences in the form of the second part of our lecture, in the form of osteomyelitis, in the form of ungrown fractures, and then big problems with the life of this patient, with his ability to work, with his, health. With open fractures of the first degree, remember, we said IOU1, most often surgical treatment is not carried out. As such, the wound is minimal, right? That is, something like a wound toilet is performed without all the other most serious stages, that is, with dissection, with revision, and so on. With open fractures of AO2 and AOU3, radical surgical treatment should be carried out with dissection of the wound, with excision of the inferior necrotic edges of the wound, with revision of the wound and, if necessary, sutures, that is, vascular surgery with vascular sutures if there is such a need, with damage to the trunk, or neuropathy, that is, suturing of nerves. Before the operation, mechanical cleansing of the wound circumference is carried out under anesthesia, often using various disinfectants. Sterile shaving of the skin around the wound is carried out. The wound is generously washed and the first, rather rough surgical treatment of heavily contaminated, torn tissues is performed. After treating the skin with dissolves and closing the surgical field with sterile underwear, he already carries out a more thorough treatment. Surgical treatment consists in a wide dissection of the wound, in careful excision of the edges. It is customary to approach the skin very gently, that is, it is not necessary to get rid of fragments of, say, skin, but subcutaneous fat can be quite radically dried up. It also quite radically approaches the expiration of non-functional muscles. Surgical treatment of the wound begins from the outside inwards and obviously dead or decomposed skin should be excised if desired. It is desirable to leave the skin with a dubious ability, yes, for repeated observation of it. There is no difficulty in this, yes, it is possible to observe the skin during dressings and, if necessary, at the stage of secondary surgical treatment, it is already possible to perform its subsequent section. Damaged fat, as I have already said, flows down quite mercilessly under the skin fatty tissue. This is the part of our with you, let's say those tissues that can be safely removed. Devitalized dead muscles. Here are the consequences of leaving dead muscles left in the wound can be extremely fatal. That is, in this case, in a day or two we are waiting for suppuration in the depth of the wound with all the developing bad consequences. Therefore, it is necessary to approach the assessment of the viability of muscle tissue very carefully. Muscle tissue should contract under our influence. It should have a healthy pink of some color. It should bleed, and its very consistency should not be so flabby. Dead muscle usually has a grayish tint. As a result of her irritation with tweezers, she does not shrink, and as a result, her blood supply is disrupted. Large bone fragments. They are not removed, they are taken out, cleaned with a bone spoon or a raspator, often washed separately in a glass with an antiseptic, but subsequently returned to their place. Small bone fragments are removed in most cases. It all depends on their number and so on. The small fragments remaining in the past may not always, say, adversely affect the junction of the alleys. Often it is a matrix, it is a medium for the subsequent development of a callus. But here it is necessary to approach in principle individually for each case. The fourth component of the modern concept is repeated surgical treatments and, as one of its types, the so-called second-hand bow. That is, to look a second time. In Russian speaking, we translate this term. Let me remind you once again that the price left by dead necrotic tissue in the wound is extremely high. Therefore, there is not exactly a requirement, but recommendations for a period of 48-72 hours, that is, somewhere on the second or third day to re-perform an audit of the wound. During the retreatment, the wound is opened again, and it follows that if we closed the wound when performing the FO, then it should be closed with provision seams. That is, with stitches that we can calmly take and, let's say, untie and get to the depth of the wound. The next moment, directly when performing a second-hand operation after opening the wound, yes, once again treat with antiseptics, that is, wash that area. Often at this moment we can detect a newly accumulated hematoma. The free space that is available there, it is necessary to evaluate the functionality of drains, if they are available, their work, and as a result, to assess unambiguously the viability of the rodder. If their inflammatory trial is detected, then this will indicate that, well, with all our desire, we could not avoid purulent inflammatory sediments. In the absence of this, the question may be raised about the need to continue draining the wound. That is, the moment of drainage of the wound can be changed to a more, let's say, more precisely, such a less bright one. That is, the tube can, for example, be removed, leaving only the rubber graduate, or the rubber graduate can also be removed. Repeated surgical treatment, second-hand, is desirable to be done by the same surgeon who performed the FO directly. Well, in this case it will allow us to analyze and compare the situation that the same surgeon saw 2 or 3 days before. Stabilization of the fracture. It's here, mind you, a replacement for the fixation method. Quite an interesting and critical approach which is currently being worked out. Previously, they often limited themselves to one of the fixation methods, that is, they used the method of external hardware fixation and brought the situation in the final to fusion. Now they often talk about replacing the fixation method. But with all the desire, the stabilization of a fracture is a very important and very necessary thing in the treatment of our open fractures. With open fractures, internal osteosynthesis can be performed, yes, that is, intermedular osteosynthesis can be performed directly from the wound, for example, with a nail or a plate. But the risk in this case of adverse purulent inflammatory consequences increases. Therefore, it is preferable to perform external fixations at the initial stage of stabilization. That is, with open fractures of the first and second degree according to the classification of REOU, yes? Well, that is, AO, the association of osteosynthesis, that is, it is about 1 and about 2. They can be treated with standard methods of osteosynthesis, but here you need to carefully perform in this case second and very qualitatively perform anti-inflammatory antimicrobial therapy. That is, in this case, again, I say, the risk of inflammation is present and it is growing. With open fractures in the third and fifth degree, it is inevitable that external fixation methods must first be performed. Careful preoperative planning is necessary, which should take into account the frequent need to place an implant or an external fixation device in non-traditional places. Implants, if possible, if necessary, should still be covered with soft tissues. It is desirable to inject them directly through the wound. This is in the case of REO1 and REO2. Additional incisions should be avoided, But if it is absolutely necessary, then the incision should be minimal, because every surgical incision, if desired, is an intersection of blood vessels. This is a violation of the nutrition of the fracture zone. In the process of performing surgical treatment, a patient with open fractures often has an increase in edema. This swelling directly near the mechanically damaged soft tissues, muscles, and so on, squeezes the vessels that pass through this area and further disrupts nutrition in the fracture zone. Therefore, it is critically important to assess the increasing edema in the fracture zone. And if our fascial cases are not damaged, it is very important to evaluate the tension, that is, the pressure inside the fascial cases, with the help of special techniques. If it exceeds the norm by 10 mm of mercury, then there is nothing harmful in this. But if the pressure exceeds 20 to 30 mm of mercury, it is necessary to apply measures to prevent ischemia. That is, at least this is an elevated position of the limb, prescribe diuretics, and if the swelling increases even faster and the difference in pressure inside the fascial fuffle with the norm is more than 30 mm of mercury, then it is shown on the fasciotomy with you. We will consider the lecture, I will not remember now, in my opinion, on the syndrome of prolonged compression, and during the lecture I will show you a video clip on performing fasciotomy. In addition to the moments of our, say, performing the stages of surgical treatment, much attention is paid to the closure of the wound. That is, wound closure, soft tissue reconstruction should be carried out as early as possible. There is a consensus that significantly contaminated, old wounds in patients with an open fracture should not be sewn up. That is, they are conducted by an open method according to the type of gunshot wounds are conducted. That is, the primary suture of the skin is possible only with open fractures of REO1 and REO2. With fractures of the 3rd degree, where guide sutures are acceptable, and with fractures of the 4th or 5th degree, they are not sutured early. An ointment or wet exhaling bandage is applied to it, that is, a tightly large swab soaked with antiseptics, and on the 5th or 8th day, you can apply provenance stitches. On the 10th or 20th day, secondary stitches are already in place and, if necessary, skin grafting is performed if you and I have a soft tissue defect. Please note that this slide presents devices that allow you to measure intrafacial pressure. The method itself is not difficult, it is invasive, but not very painful. That is, a small thin needle pierces the facial case and we measure the millimeter of mercury, respectively, the fascial pressure inside. In more detail, I would like to focus on the 5th point of the concept on the moment of stabilization of fractures and replacement of fixation methods. That is, as we said earlier, with small, minor damage to each soft tissue integument, that is, according to the classification, it is AO1 and O2. In principle, in this case, traditional methods can be applied, that is, on bone or intraosseous osteosynthesis. With careful antibacterial therapy, with good quality of primary surgical treatment, with early admission of the patient with a not very contaminated wound, such techniques take place and, in essence, the effect of these techniques, well, let's say, is highly likely to be without complications. In the case of more severe damage to the skin and soft tissues, that is, it is REO 3, 4, and 5. Of course, such a method is extremely, let's say, dangerous in terms of, but also without inflammatory consequences. And here a two-stage method of fracture stabilization has been used more and more often lately. That is, they begin. That is, the primary does not necessarily have to be final and it does not necessarily have to achieve accuracy to fixation at its first intervention. Sometimes it is reasonable to apply temporary stabilization of the external fixation device. The task is to preserve the length of the limb, correct the displacement, and leave a more accurate comparison for later. At the time when there will be a decrease in edema, when an assessment will be made, say, of the situation with the wound, when the wound will be cured, and then there is an opportunity to replace the method that is not the most convenient for the patient, not the most accurate method outside of focal fixation with the help of apparatuses with other techniques. That is, severe open fractures with significant soft tissue damage require stabilization, just like any other fracture. And as a rule, an external fixation device is used. Here is the algorithm presented here on the right on the slide. After the healing of the soft tissue frames, the external fixation apparatus is changed either to bone osteosynthesis plates with screws, or to intermedular osteosynthesis with a rod. That is, the concept of primary external and secondary internal fixation. The proportion of infection after secondary intermedular relatively osteosis is relatively high, that is, the channel from the rods or from the spokes of the Ilizarov apparatus is often infected. Therefore, if there was a moment of infection in the anamnesis, say, in the area of the passage of the spokes of the Ilizarov apparatus, then these are contraindications for secondary, say, intermedular osteosynthesis. Or it is possible to use the method without drilling the bone marrow canal. This is the use of non-massive structures, for example, the so-called shadows. That is, the shades are most often used, of course, in children's practice. That is, these are elastic rods that are used in pairs for intermedular osteosynthesis. Replacement of the external fixation device with a plate in the future is also possible after the healing of the soft tissue wound. But the location of the plate should be planned so that it does not come into contact with the places where these very spokes or rods are inserted at the first stage, when external fixation devices are used. At the last wedding, we talked about the tactics of the approach to the choice of the fixation method. Let's to some extent once again systematize our understanding of what is the concept of the fixation method. So, fixation can be carried out in the fracture zone with the help of external fixation devices. That is, the devices can be spoke, rod with extracortical fixation and a combined device. In addition, we talked about intermedular synthesis, when a metal structure is inserted into the bone marrow canal. This can be done without investigating the bone marrow canal. And in this case, we mentioned spokes, awnings, modern metal structures that can be blocked with the drilling of the costa of the cerebral canal. In this case, of course, there is a risk of spreading the infection in terms of our treatment of an open fracture, but this allows you to install a more massive and more durable metal structure and, as a result, make an intermedular osteosynthesis is more stable. It was also mentioned about bone synthesis, when you and I can install a plate and fix it with screws, or the so-called bone immersion synthesis simply with screws. It is worth dwelling in more detail on external fixation devices, which are often used for open fractures. External fixation devices are the method of choice for the treatment of heavily contaminated, infected wounds in the case of our treatment of open fractures. An external fixator guarantees the healing of soft tissue wounds and a fairly stable fixation in the fracture zone. The main disadvantage of the external fixator is the patient's weak tolerance to long-term wearing of the device. There is a significant risk of infection during the passage of rods and spokes, especially along the area of their passage through the muscles. Ideally, when the rod or screws of chance, now we will say what it is inserted into the bone, located directly subcutaneously. Let's say the tibia is in the area of its front part of the lower leg, where the bone itself is located subcutaneously. The device is less convenient in cases when the bone is surrounded by a pronounced muscular fuffle, for example on the hip or on the shoulder. External osteosynthesis can be used as an initial temporary one. We have already talked about this, and it is desirable to change it to intermediate or to bone osteosynthesis in the future. In the following slides we will talk again about external fixation devices. Here, pay attention, there are two main types of special devices. special devices were actively developed in our country. There are even, let's say, a separate institute. We have a Shooting Research Institute of Traumatology and Orthopedics named after Yelizarov in the city of Kurgan, which is famous for the fact that it was here that the most famous apparatus, the special apparatus, the Yelizarov apparatus, was developed within its walls. This is a device with crossed spokes, and there were other models besides it. This is a Kulber's device, not made of metal, made of textilite, the apparatus of the wolf in Oganessian. We'll see it on the next slide. In addition, there are devices with single-plane spokes. So, special machines with crisscrossing spokes. The Yelizarov apparatus. Gavril Abramovich Lazarov created this device in 1951. It was probably one of the most widely used external fixation devices in our domestic traumatology. But on the right is the Volkov Oganessian apparatus, where not rings are used, but such semi-rings. In essence, of course, there is a rational grain in it, because it is easier to dress such a device, yes, when performing an operational act. Knitting machines with single-plane knitting needles. The most famous of them is the Shoyui bone apparatus, which made it possible to fix fractures quite well. The strongman's device is of course simpler and, in fact, its qualities in this case are significantly fixed. Rod devices. Here, according to this method, they worked abroad to a greater extent. And of course, rod devices have found a very wide application there. It is based on a rod, and in our country the rod of chance is most often used. Here, pay attention here below at the wedding, they are presented with vertical carving and a stubble of chance with Pangios carving. Accordingly, the rods inserted into the bone substance can subsequently be fixed with the help of various That's to the point that at the moment there are devices through bone devices with the properties of computer navigation. The beauty of these devices lies in the fact that after performing a qualitative X-ray examination, the computer, assessing the location of the rods, evaluating, say, a superimposed power for such device with navigation, clearly composes an algorithm. The rotation algorithm in this case is the data of the rods, which allow you to change the location of the bone in space, taking into account the three-dimensionality of this, say, research method. And the finale of our manipulations with you on the rotation of these, say, bolts and nuts will be that we will clearly and accurately compare the bone fragments. In addition, there are such devices that have not found wide application, but essentially have, let's say, the right to life. These are extracortical fixation devices. Here, pay attention, this is without a rod device for external fixation using clips. Another of the cortical fixation devices, the so-called ortho-SUF, which, in this way, here on the next slide we will see, can be fixed by an oblique substance. Here is a schematic image and an X-ray with fixation by the ortho-SUF apparatus. Approaching the issue of considering open fractures, just a few words should still be said about the medical treatment of open fractures. In particular, the presence of damage to the skin, the presence of a massive wound poses a great risk for the development of an infectious complication. Therefore, antimicrobial therapy is often prescribed for preventive purposes. If this is an inpatient pathology and the patient is hospitalized for treatment in a hospital, then the drugs are used post-lateral. The drug of choice in this case at the moment is ceftriaxone. This is a cephalosporin produced in our country, which costs moderate money, which has the widest spectrum of antimicrobial action, and in this case it should be taken into account that the drug is used as a preventive course. That is, as a rule, the course is short, 5 to 7 days. In the case of the correct implementation of the FO, in the case of a qualitative, let's say, procedure for treating wounds with antiseptics, in the case of the use of ceftriaxone in this case and the absence of inflammatory processes, it usually takes a week. A 5 to 7 day course. Patients who remain treated on an outpatient basis, in this case an open fracture with outpatient treatment. The use of a parenteral way of conducting well, it's probably not reasonable here after all. Therefore, most often the drug of choice is a drug from the group of modern synthetic penicillins, that is, it is amoxicillin. Ideally, amoxicillin is covered with clavulinic acid. That is, amoxiclav. Here at the wedding, which is presented here, in a purely schematic form, you are presented with these two drugs. Much attention is paid to the prevention of a formidable complication when receiving patients with open appointments. A specific infection is tetanus. Without fail, the patient must be interviewed, preferably even confirmation in documentary form, whether he has a history of life, that is, tetanus immunoprophylaxis. If more than 5 years have passed since the last vaccination, then it is necessary, or there is no way at all to confirm his vaccination, then a full course of emergency prevention is used when 1 milliliter of tetanus toxin is injected and a full dose of serum, a preventive dose, that is, 3,000 international units, is applied. Fractional, without exception, we will go through this topic in detail with you next semester, when we will sort out the wounds. The wounds are infected. When treating open fractures, attention should be paid to the fact that these fractures heal more difficult. The injury zone here has been damaged to a greater extent. There is much worse nutrition of the fracture zone, so there is a need to stimulate consolidation. In particular, to strengthen the possibility of healing, that is, the falsification of corns. Therefore, calcium preparations in combination with vitamin D are also desirable in the treatment of fractures, especially in the treatment of open fractures. So, the next part of our lecture is devoted to such a formidable disease as osteomyelitis. In particular, traumatic osteomyelitis is one of the frequent complications of fractures, in particular open ALIs. Osteomyelitis comes from the Greek words osteon, bone, and myē, brain. This refers to the bone marrow. The end of ITI indicates that this is a purulent inflammatory process. In fact, osteomyelitis is a purulent necrotically purulent inflammatory process that develops in the bone and bone marrow, as well as in the surrounding soft tissues. According to the meaning of the word, osteomyelitis is an inflammation of the bone marrow, although in fact, the features of even post-traumatic osteomyelitis are not always. The involvement of the bone marrow here is important and critical. The term under this name was introduced into the medical literature by the famous French Dr. Raynaud in 1831. Attempts to change it to some other digestible term that would more correctly reflect the essence of the process were examples. It was suggested to call such a disease atheitis, panastitis, but with all the desire, for some reason these attempts were unsuccessful. And to this day, despite the fact that, in fact, there is probably a logical error somewhere in the name, but this disease is called osteomyelitis. Inflammation of the bone in fact has been known for a long time, even in the writings of Hippocrates, in the writings of Avicenna, Sargalen, there is a mention of the inflammatory process in the bone. In 1880th year, Louis Pasteur isolated a microbe from the pus of an osteomyelitis patient, that is, from the open fistula. He called it Staphylococcus. It was the first of the most famous microorganisms that was discovered. Subsequently, it was clear that not only Staphylococci cause osteomyelitis. From here, let's start classifying osteomyelitis. Osteomyelitis is usually divided into nonspecific, which is caused by a nonspecific pyogenic handicap. In 90% of cases, this is the same Staphylococcus discovered by Louis Pasteur. In particular, there may be streptococci, E. coli, Pseudomonas aeruginosa can cause nonspecific osteomyelitis. A separate group includes specific osteomyelitis. Here we have a specific flora. These are bone tuberculosis and tuberculous osteomyelitis. It's brucellosis, syphilis. In fact, quite rare diseases at the moment, but they are present, they exist, they cannot be forgotten. The next type of classification will be the dependence of, that is, hemolyte on the way in which the microorganism enters the body. In the scope of the general surgery course, you have undergone endogenous or hematogenous osteomyelitis. In this case, the causative agent of purulent infection is introduced into the bone most often through the blood, that is, hematogenically, yes, from a purulent focus already existing somewhere. Whether it is a small hearth, there is a boil on the flashlight, or a larger abscess, a phlegmon. That is, there is a possibility of contact penetration from an infected wound. But here it is already possible and more correct to talk about exogenous osteomyelitis. That is, post-traumatic osteomyelitis is a classification of exogenous osteomyelitis after open fractures. Firearms in a separate group carry out such a thing as a gunshot wound, often with a gunshot fracture, which entails a gunshot exogenous osteomyelitis. Another form of the existence of an exogenous osteomyelitis, by the way, a fairly frequent form, is postoperative osteomyelitis, which is essentially nitrogenism. After performing any operations on the bone, let's say osteosynthesis, yes. With insufficient compliance with the norms of asepsis, contamination of the bone wound by microorganisms is possible. And in this case, it is customary to talk about postoperative osteomyelitis, especially often after surgery. The cochlea occurs after the spoke methods of treatment. For example, carrying out spokes during skeletal stretching. Even more often when using special or rod external fixation devices. In principle, this can be explained by the fact that it is caused by non-compliance with the rules of asepsis. Moreover, patients are often in conditions that are not necessarily sterile. If it is skeletal traction, it is a ward in which there are other patients nearby who may be sources of purulent infection. If these are hardware methods, then it is not necessary that the patient is in the hospital for his entire period. This is why the hardware method is bad. That is, one of his bad sides of external fixation devices is that a person is at home, in fact, on outpatient treatment, and at the same time, monitoring the wounds on his body from the passage of spokes is his responsibility. He can't always do it right. It is not always reasonable to approach the moments of septic, antiseptic, treatment of these wounds. Another form of uveitis is contact osteomyelitis, when there is a transition of the inflammatory process from the surrounding tissues. That is, the existing phlegmon spreading deep can lead to the fact that the purulent inflammatory process will pass to the bone substance. In the final we will get contacts of exogenous osteomyelitis. Post-traumatic osteomyelitis has 3 stages of its course. Sometimes they are called phases. In this case, please do not confuse here in the name of the phase data with exactly the same concepts in other clinical disciplines, where under such names there are forms of any pathological process. Here it is a stage, and it is clearly visible and, accordingly, has its own nuances and clinics and treatments. So, 3 stages, it is acute with the transition to subacute from the subsequent chronization and chronic stage of post-traumatic osteomyelitis. As a rule, osteomyelitis begins post-traumatically acutely. In favorable cases, it ends with recovery. That is, the phase stops, that is, the flow of the process stops at this phase. In unfavorable cases, the process passes into the 3rd, chronic phase of the course. The acute stage of osteomyelitis, like any violent purulent inflammatory process, is accompanied by a serious hectic fever, pronounced intoxication of the body, which manifests itself in weakness, headaches. When performing instrumental, that is, laboratory tests, we note the phenomenon of leukocytosis, the phenomenon of anemia, soy increases, taking into account classically, if the causative agent of post-traumatic osteomyelitis is an ordinary homogeneous classical staphylococcus, well, or any homogeneous handicap, we note the shift of the leukemia formula to the left. The tissue in the area of the affected limb segment is usually edematous, hyperemated, sharply painful. The wound itself that was present, either it was an open fracture, or it is a postoperative utility. Early inflamed, there is purulent, they are judged. Gradually, against the background of treatment, our inflammatory phenomena subside and the process can go from an island to a chronic state. That is, the pain decreases, they become aching, and clothing passages begin to form, which may look like a complex system of channels and come to the surface of the skin sufficiently in a remote place from the purulent focus itself, in the area of inflamed bone. A moderate amount of purulent discharge is released from things. Like any chronic process, it can go into remission. In this case, the patient's condition is satisfactory, more usually disappear. What is separated from things becomes scarce, sometimes candles are closed. The duration of remission can be completely different, from several weeks to several decades with diabetes. It strongly depends on the general condition of the body, on age, on localization. The development of relapse contributes to a decrease in the body's defenses, a decrease in immunity. After that, the closed candles open, yes, pus begins to stand out. And in fact, its relapse may resemble an erased picture of acute osteomyelitis, that is, a return again to the phenomenon under the acute stage with pain in the area of the damaged limb, with hyperemia in this area, with general intoxication, with leukocytosis, with an increase in soy. That is, the whole picture again repeats the acute inflammatory process. The moment of instrumental diagnostics. Here in the acute stage, most often we cannot see pronounced changes on the part of the bone. Instrumental diagnostics is X-ray diagnostics. The minimum volume is radiography, more accurate ones give us a picture of the performance of computed tomography. When the process is chronicled, here already on the radiographs we can see for sure that the inflammatory process has led to a change in the bone substance. Yes, this may be manifested by the formation of sequestration in the zone. That is, we can see the area of sclerosis around the inflammatory process, the area of discharge directly in the area of the astral box itself, where a fragment of the sec vessel floats inside the pus, that is, the remaining part of the bone substance that is not completely melted. With things that open to the surface, you can contrast. The method is called fistulography, when a water-soluble contrast is introduced through things, and then when performing an X-ray examination, we can notice, clearly see a qualitative picture of these very fistulous passages. So, the treatment of post-traumatic osteomyelitis. Let's divide the treatment into two large areas. This is a conservative treatment and the moment of surgical treatment. The place where the treatment is carried out is necessarily inpatient conditions. Exacerbation of osteomyelitis, acute post-traumatic osteomyelitis, and is treated in a hospital. Most often, either a special purulent traumatology department is used for this is in large centers, or purulent chambers are allocated as part of the traumatology department, or these are chambers of the traumatology profile of purulent surgery. What does conservative treatment include? It necessarily includes full-fledged antimicrobial therapy. Antibacterial therapy is performed. It is desirable to perform it with a determination of sensitivity in the microflora. But initially they start with broad-spectrum antibiotics, with massive antibacterial therapy. Sometimes no drug is used. The drug of choice is the same ceftriaxone that is used parenterally. Sometimes the second link comes with intravenous use of metronidazole. If it is impossible to apply ceftriaxone, allergic reactions, and so on. The drug of the second link is a very interesting antibiotic, lincomycin. An antibiotic with a very long history. The antibiotic, which was invented by one of the first, began to be used in the 60s and has not lost its effectiveness to this day. The reason is that the antibiotic of this particular name was not widely used, and the main scope of its use is exactly the one we are talking about now. Lincomycin has a clear tropicity to bone tissue and has found its use exclusively in purulent traumatology. If it is impossible to use this antibiotic, there is also a drug gentamicin with its not very good properties cytotoxicity, with nephrotoxicity. But with all the desire, in the absence of anything else, it is broad spectrum, it is actively used. The regimens for taking antimicrobial drugs are quite long, that is, they reach 3 to 4 weeks. And usually in this case there is a replacement. That is, after a 10-day period of application of ceftriaxone after seeding directly, that is, when we determine the microorganism for sensitivity after determining the antimicrobial agent that has the greatest effectiveness, it begins to move to it. That is, sometimes it can be drugs from a number of quinolones, ciprofloxacin, sometimes any other antimicrobial drugs. In parallel with powerful antimicrobial therapy, taking into account the intoxication phenomena we have, the question of proper detoxification therapy is very acute. With intravenous administration, sometimes a sufficiently large number of crystalloid solutions, colloidal solutions of the detoxification series, which allows you to cause hemodilution, bind toxins, yes? It stimulates our own detoxification mechanism to the, let's say, activation and qualitative elimination of toxins from the body. In addition, it is possible to use methods of extracorporeal detoxification. We will analyze these techniques in detail next semester. It is worth mentioning here that the plasma of the Federal Reserve is selective. Non-selective plasma of the Federal Reserve with severe intoxication is often quite used in purulent traumatology and is very effective. Considering that the process is prone to chronization or is already chronic. The topic of stimulating the immune system is quite active. This is even more critical and important due to the fact that bone tissue has certain features. The peculiarity of the originality of the immune response. Roughly speaking, microorganisms are immured inside the bone tissue and access to them as their own immune, say, means, and access to antimicrobial agents from the category of antibiotics is very difficult. This leads to the fact that often after years an aggravation may occur again. That is, remission, as we have already said, can take years. So, immunotropic drugs that stimulate immunity are actively used. Polyoxidonium, Golovit, immunal, banal cyclophoran. All this can help strengthen immunity. The stimulation method has also been widely used. Stimulation of our white bloodletting germ, stimulation of protective forces. These are ultraviolet blood training, laser blood training, various mechanisms of selective ultraviolet irradiation, when not whole blood is trained, but it is the blood clot mass that is trained separately. Given such a large volume of antimicrobial effects on humans, our microbiota is seriously affected. Sometimes all this in the final can lead to dysbiosis, so probiotics, drugs that normalize the intestinal microflora, are prescribed. Linex, Biform, that is, in this case, taking into account the planned long-term antimicrobial course, this is mandatory. Drugs that improve microcirculation. As we have already said, initially in the area of an open fracture, if the cause was an open fracture, or in the area of surgical impact, there is damage to the microcirculatory bed. This area is poorly supplied with blood, and in most cases this is one of the components, yes, the cause of our osteomyelitis. Therefore, it is necessary to prescribe drugs that improve microcirculation. This is pentoxifylline, Trental, that is, a variant of riopoliglucin with its powerful antiplatelet properties as a component of colloidal infusion therapy. Local treatment. Local treatment in the area of our wound itself with the use of, that is, the performance of dressings should, well, as with all desire, contain modern antimicrobial ointment forms. Let's say the same, starting from the banal, not the most effective, but cheap levomecal, ending with a water-soluble other ointment, myromystin ointment, dioxidine ointment. Proteolytic enzymes are very actively used both in the form of, well, quite old ancient trypsin, chymotrypsin, and in the ointment form, the ointment is present containing trypsins, and in the form of nets. Now let's talk about the features of surgical treatment of post-traumatic osteomyelitis. As with the treatment of any purulent inflammatory process, a prerequisite is high-quality drainage of the purulent focus. As the warrior Yeseniki wrote at the time, if there is pus, it definitely needs to be released. Well, roughly speaking, the phrase saw pus open. That is, it is necessary to ensure adequate proper drainage of the purulent inflammation zone so that the pus flows away and does not accumulate. It is actively used, except for banal drainage with the help of tubes, actively through skin lavage. That is, the installation of so-called drainage and flushing systems. Or it is a two-light tube that is installed in the area of the inflammatory process. Or as follows, on the next slide you will have a video clip with the operation, which will show the installation of a flushing system in the bone marrow cavity. That is, through one end of the tube, the antiseptic will be washed and supplied, through the other, this antiseptic will flow out, respectively, along with the pus. An important point is the performance of necrectomy, that is, excision of non-viable, already mortified inflamed tissues. Moreover, necrorectomy is performed within the limits of healthy tissues. If you take the bone substance, it is dense and durable. This causes certain technical difficulties. Non-sequesterectomy is performed with the help of quite serious, well, roughly speaking, carpentry tools. When a milling cutter is put on the end of the drill and the bone substance is milled to the so-called blood due, that is, healthy bone substance. Or it is performed with the help of acylating beer, that is, a tool similar to a renovator, bone sawing and osteotomy to a healthy substance. That is, it is a NEC, sequesterectomy. In manual execution, a chisel, yes, a chisel and cut down to a healthy one. Again, on the next slide in the video, you will be shown performing this very operation. Yes, that is, it is a bone plastic trepanation of the bone of its autopsy. This is with the help of a cutter neck sequestertractomy and, accordingly, drainage to close this process. Considering that the root cause of our post-traumatic osteomyelitis was a fracture, the question of the correct stabilization of our fracture is necessarily raised. If we have chronic osteomyelitis on the background of an already fused fracture, then the tactics are relatively simple here. If we have an incompletely fused fracture, and against the background of osteomyelitis, quite serious difficulties arise here. Firstly, the rotation process itself will experience serious difficulties. If an implant is already installed, then we face a dilemma. Remove the implant from the area of inflammation or wait for now. The approaches are tactically quite different. Some believe that there is a great need to immediately remove the implant, and in this case it is a source of infection or supports infection. Some believe that it makes sense to wait, perform massive antibacterial therapy, perform proper drainage, and it is quite possible to preserve this very stabilization of the fracture. But here again, all cases in this case are individual. If we remove the implant, then stabilization is usually carried out either by external mobilization, for example, with a plaster splint, or by applying an apparatus, an external fixation apparatus, when it is carried out outside the focus, away from the inflammatory process. Consequences of bone damage. The consequences of purulent bone melting are usually accompanied by the formation of a bone defect. Bone grafting with a muscle flap on the feeding leg, when the defect of the bone substance is replaced by a nourished tissue. In this case, we hope for rebirth, the rebirth of various pluripotent cells into bone matter. A possible option for using bone grafting with spongy bone, which are usually taken on the ilium, or it is a fragment of the fibula. That is, Maripsova, if you remember, is a rudimentary bone, and it is used as a replacement part of that very bone defect. Sometimes osteogenesis stimulants are used. Then, at the end of our lecture, there will be various know-how options, where you will also be shown the nuances of using bone cement, when in essence it is no longer an implant, it is already a foreign substance based on methyl acetate, which is just glue that is poured and sealed with this cement a bone defect. Closed soft tissue defects also present serious difficulties. Various options for skin grafting up to serious ones, which you will have shown not on the next one, but through one slide. Italian skin fascial plastic surgery will be shown there, and with a sufficiently powerful skin muscle flap, which will simultaneously perform the function of closing the soft tissue defect and also a muscle flap itself, immersed in a bone defect, will be presented to you as a treatment for a bone defect. That is, there will be chronic osteomyelitis, sequesterectomy, and Italian plastic surgery with a skin muscle flap on the feeding leg. Here is a request on the next 2 slides to approach this carefully and watch the video clips to the end.
Total lesion of the right femur with hematogenous osteomyelitis. Previously, the patient was operated on several times. Osteoplastic trepanation of the femur is shown. To access the femur, we make an incision of the skin along the anterior lateral surface of the thigh. We shift the straight and inner wide thigh muscles. The intermediate broad thigh muscle is delaminated. During the revision of the wound, the flow of pus from the parosal space and the bone marrow canal is visible. Removing sequesters. We create access directly to the bone marrow canal. The scheme of bone plastic trepanation. We perform a U-shaped osteotomy of the femur. With the help of chisels, the bone marrow canal is opened in the form of a bag. In this case, a vascularized musculoskeletal fold is formed. Thus, optimal access to the lesion is achieved. We are removing multiple endosteal sequesters. We process the walls of the bone marrow canal, restoring its patency. We drill a hole in the bone for silicone perforated drainage. We install a perforated drainage tube in the bone marrow canal. After the surgical treatment is completed, the musculoskeletal flap is returned to its place and fixed with separate U-shaped sutures. A bandage with a water-soluble ointment. Radiograph after surgery. After the inflammatory process subsides, the edges of the wound dry up. and we cover it with local fabrics. In the post-operative period, we carry out a long-term washing of the bone marrow canal with antiseptic solutions. Then we remove the drainage. The wound healed by primary tension. Chronic osteomyelitis of the tibia. Sequestration in the non-muscular lower half of the lower leg. Surgical treatment is indicated. Italian plastic. To access the bone, we excise scar-altered tissues. We perform sequester-ectomy. We treat the walls of the sequestral box with marginal resection of the bone until the appearance of blood dew. Additionally, we excise the altered skin areas, taking into account the size of the donor flap. To replace the formed bone cavity and the defect of the integumentary tissues, we mobilize the musculoskeletal calf flap from the opposite shin on the temporarily feeding leg. Type of skin muscle flap after transplantation. After 4 weeks, the feeding leg is crossed and the final stage of plastic surgery is performed. Complete engraftment of the flap. A CT scan after surgery. A year after surgery, there is no recurrence of osteomyelitis. The condition of the skin is satisfactory.
We have just reviewed 2 videos in which you were presented with quite serious operations for the treatment of post-traumatic osteomyelitis. In this case, several subsequent slides will show you some techniques used nowadays in medicine, in surgery, which can be designated in one word: know-how. That is, various modern approaches. Do not be alarmed by some modern approach for several decades, but to this day they are still not so widely implemented and interest in them has not dried up at all. For example, here is the so-called version of a vacuum bandage, when a bandage superimposed on pus in the inflammatory process is connected to an active vacuum aspirator, which, firstly, ensures the creation of an airless environment and, as a result, the ability to fight aerobic handicap, and the possibility of forced drainage, that is, outflow. On this slide, the techniques are not to say that they are new, but the grain was based on a technique that is about 40 years old, and about 40 years ago such deposited forms of antimicrobial agents as the so-called septopal beads were invented. They were not widely used in traumatology, but the idea itself was very interesting. That is, when performing primary surgical treatment, when performing wound drainage, or when performing secondary surgical treatment in this case, that is, performing various necroectomy options in the area of purulent inflammatory process, the substance was left in a special deposited form. Septipol is gentamicin, in fact, not the safest and simplest antibiotic. But the very principle of this technique was that the gradual planned resorption of this drug. Local exposure around itself is precisely antimicrobial properties. This has found a use. In the following slides, we will talk about this with you and... Well, we continue the situation with the previous slide. This is the process of eliminating the inflammatory process of osteomyelitis and in the final healing. Yes, healing took place in a peculiar way. You see, there was even a fusion between two bones as a result of the inflammatory process, but healing was achieved. Another of the cases that shows us exactly the time of occurrence well. You see, these are foreign pictures. 81st year, the month of January. Judging by the Venus badge, yes, this is a woman of 69 years old. And here we have the same method when a long-term absorbable antimicrobial drug is deposited in the deposited form. Here is the outcome of this process. Another interesting topic for both the prevention of inflammatory complications, especially iatrogenic inflammatory disorders, that is, postoperative myelitis, and in general the fact itself, which allows there to reduce the risk of the inflammatory process, is precisely the approach to, even probably it is not medicine, but engineering, the approach to implants. That is, modification of the implant itself to minimize the risk of inflammatory complications. What can be done here? Electropolishing up to laser polishing, when the metal structure is polished not just to shine, it is polished to a state of molecular smoothness. In this case, it greatly hinders the adhesion of microorganisms, adhesion and reproduction of colonies on the surface of such an implant. Antimicrobial coating. Yes, there are such options when special substances are implanted on the surface of the metal structure, some of them with antimicrobial properties. There were methods of silver impregnation on the surface of the metal structure. You remember that silver has quite a powerful antimicrobial effect. In addition, various antimicrobial drugs can be impregnated with them. In addition to all this, there is a variant of nanocoating metal structures with various titanium salts. It has both antimicrobial properties and remarkable anti-corrosive properties. In any case, any metal structure immersed in our body is affected by our immune system, our body. The body tries to destroy the alien metal structure. So, special nanocoatings, you have seen them, you know, they are different, they have a gilded or blue color. Such coatings provide a more resistant corrosion resistance, in terms of diffusion, for example, greater resistance for the implant. Here is a rather interesting situation when metal structures implanted into the human body are coated with an organic compound. These are American developments, and in this case, hydroxyapatites are covered with implants. The body begins, let's say, to make mistakes in terms of aggressive effects on such implants and perceive in this case as a substance similar to human bone. And the corrosion of such implants is significantly reduced. Plus, here on this slide, an innovative external fixation device is also shown. Here, the system through the dermal core, say, osteosynthesome, is not something with large degrees of freedom. You see, this device is presented here in a very unusual articulated plan. Not only does it allow the rods that are implanted into the human bone to be fixed quite qualitatively at different angles, but also the device itself is made of an interesting material. Fiberglass is used here, in my opinion, more precisely, carbon fiber. This is carbon fiber. The device is inert to the human body. The X-ray machine is negative, so it is enough, it does not interfere, let's say, when performing control-logical studies. Modern diagnostic techniques allow us to see quite a lot in terms of our treatment of osteomyelitis. Look, here is the moment of angiography, the moment of the combination of angiography with computed tomography, well, in this case, in the presence of a metal structure, or with magnetic resonance imaging in the presence of metal. As you remember, you cannot use MRI diagnostics. But no one prevents us from performing vascular contrast, yes, to assess the situation with the blood supply to the fracture zone, the blood supply to the zone of the inflammatory process of osteomyelitis. And to realize and understand, and whether we will experience problems with the blood supply to this area. Let's roll back a few piles and remember the septal beads. Here is a modern analog of what we can come to in combination with one more interesting know-how. This is a biodegradable construction. It cannot be called a metal structure. The screw in this case is mainly made of lactic acid. The beauty of it is that it does not need to be taken out. Here is this metal structure. Well, not metal, this design implanted in humans resolves itself within a year. And why did I say let's go back to septopore? That's exactly what this screw is also impregnated with ciprofloxacin. Well, let's say, a fairly modern Henelan. In addition to screws, there are also rods. As you can see, a biodegradable pin is presented on the right, which can be implanted into the bone marrow canal. After fusion, after some time it will resolve itself from the body. Well, here is a comparative moment from the surface of a conventional screw and a screw that was impregnated with ciprofloxacin. How many colonies do we have growing on the surface of such imports? Cement, bone cement. Quite a modern interesting topic which has found application in the treatment of, say, fractures caused by osteoporosis, in the treatment of compression fractures of the spine, and has now become actively used in the treatment of, say, filling in bone defects after, say, inflammatory processes in the bone. That is, when performing sequesterectomy, this cavity, this defect of bone substance can be filled with such bone cement. In addition to performing, say, its properties as cement, an antimicrobial component is also clearly added here. See the word gentamicin written in large letters. That is, in this case, the antimicrobial component with methylquate in total will give us the opportunity to replace the bone defect. After some time, at the temperature of the human body, this thing will harden. Well, we will get such a bone cemented, say, cavity. This will be the end of our lecture today. Outcomes, yes, that is, there are various variants of complications of osteomyelitis. What can osteomyelitis lead to? Locally, to the development of other inflammatory processes in soft tissues, to the formation of abscesses, to the formation of phlegmon of soft tissues. If the purulent process spreads to the joint, then to the development of purulent arthritis. A bone subject to osmolytic processes, after some time, even if we cure chronic osteomyelitis with all the desire, it will not be recreated in its full, say, pristine state. It will be sclerosed, it will differ from normal bone in much less strength. Therefore, pathological fractures is one of the complications of osteomyelitis. The moment of development of false joints, that is, when we have a moment of immediate consolidation, a non-fused fracture, and the final may be the development of false joints. A banal fused fracture may have a deformation. In the final, we will have a bone deformity and as a result of a violation of function. Contractures due to prolonged immobilization, possibly due to the inflammatory process in the joint area and damage to the tendons of the ligamentous apparatus, contracture with impaired mobility may develop in the final, yes? The scars that form on the skin, these fistulas, this is a degenerated scar tissue, with all the desire, will prevent us from the proper functioning of the joints. Up to the development of ankylosis and loss of mobility. Well, basically it is already with purulent melting of the joint itself. A long-existing inflammatory process can very often lead to immunization in the final. You remember, there was a phrase that chronic osteomyelitis can last for decades. Such long-term inflammatory processes can lead to the formation of this zone. A common complication, but everything is quite simple here. The process can generalize, go into sepsis. A long-term existing chronic inflammatory process leading to chronic intoxication can damage our detoxification apparatus, cause mmL doses, in particular kidney amyloidosis and secondary anemia. It is also one of the options that constantly haunts patients with chronic osteomyelitis. This concludes the lecture. Classic. We spent an hour and 20 on a lecture for one couple. That's it. Have a nice day. Goodbye.